Good morning, good afternoon, or good evening, depending on your time zone, and welcome to this virtual keynote for the RDA 15th Plenary. My name is Andrew Treloar. I'm one of the co-chairs of the Plenary 15 Organising Committee, and like you, I'm sorry that we're not able to do this event in real life in Melbourne, but delighted that our keynote speaker has been willing to give the keynote in this alternative mode. This is a webinar and we are recording it for people who can't make this particular time. We will share the slides and the recording after the meeting, so if there are colleagues who are unable to attend, then you'll be able to send the link to the slides and the recording to them, and we'll also make it available through the RDA Plenary virtual program. The link for the virtual plenary program will be made available on the screen at the end of this talk. As you will have been told, you've joined this webinar in listen-only mode, which means you are muted throughout the webinar. If you want to ask questions, you have a questions panel in your interface. Please feel free to type questions into the questions panel during the talk or afterwards, and we will ask the speaker to respond to them. There are two kinds of questions we can imagine you might ask. One is if there are problems with the actual presentation itself, you can't hear what's going on, or your image disappeared. So for those sorts of technical issues, please let us know as soon as possible. And we'll get onto that straight away. Questions of content, though, we'd like to hold until the end. We'll stack up the questions, and I will be feeding them to the presenter for her to respond. So with the formalities out of the way, let me now introduce our keynote speaker for today. Priyanka, if you can briefly turn on your webcam, please. So, welcome to Priyanka Pillai. Priyanka is an academic specialist at the University of Melbourne. She has a background in bioinformatics and software programming, and at the moment she is working as a research data steward for a part of Melbourne called the Melbourne Data Analytics Platform, which is working to increase data management capabilities across the university. Priyanka also works as a health informatics specialist for a group called the Australian Partnership for Preparedness Research on Infectious Disease Emergencies. The acronym that you will see on the right there is APPRISE, which is a centre of excellence based in Melbourne at the Peter Doherty Institute for Infection and Immunity. Her role as a health informatician for this APPRISE Centre of Research Excellence supports a geographically distributed network of data holders and researchers, and provides strategic advice to facilitate national and international information sharing. And you'll hear some of those threads in her talk. Priyanka has been involved with science mentoring programs at the university and is an advocate of the inclusivity of women in science. I'm delighted to invite Priyanka now to talk to us about the role of data in a rapid and coordinated response to infectious disease outbreaks. And I note, by the way, that this topic was chosen just as the COVID outbreak was kicking off. So it's either good or bad timing, depending on your point of view. Over to you, Priyanka.
Thanks, Andrew. Thanks for introducing me. Can everyone hear me? If not, please let Andrew know in the question box. I'm going to stop sharing my webcam now to make sure that everyone has access to the slides and there are no bandwidth related issues. Am I still visible? I think people can still see me.
I can still see you, so you haven't managed to kill your webcam. And people are saying the audio is fine.
Okay, great.
Okay, that's it.
I'm gone now. Great. Thank you, RDA, for giving me the opportunity to talk about the role of data in a rapid and coordinated response to infectious disease outbreaks. And as Andrew said, it feels quite real now. Things have evolved quite rapidly since the time I was invited to give this keynote address. So I've been updating some of my slides quite regularly. I think the last one I updated was in noon today. The RDA plenary theme is data for real world impact. So I've tried to keep my content as close to real world as possible. So these are my contact details. I'm always up for nerding out on data, so please reach out to me if you have any questions. I'm also quite active on Twitter. Andrew has mentioned and has introduced our platforms and the different groups that I work for, but I'll quickly give a bit of an intro. So Melbourne Data Analytics Platform is a multidisciplinary group of data specialists and stewards who collaborate with researchers across different disciplines. We work with our collaborators on data-intensive research, computation, and related infrastructure. We're also able to aid in data stewardship and domain development of high-value data collections, and we're based at the University of Melbourne. And APPRISE Centre for Research Excellence, the Australian Partnership for Preparedness Research on Infectious Disease Emergencies. It's a bit of a mouthful. It's an Australia-wide network of experts involved in medical, scientific, public health, and ethics research. Many of the experts are based at the Peter Doherty Institute, and a lot of our experts are distributed around Australia. So our national consortium has been developing research in the last few years to inform Australia's emergency response to infectious diseases. APPRISE has now responded to the COVID-19 pandemic with fast tracking of about 16 new projects across a range of disciplines that addresses critical areas of research. My health informatics role with APPRISE draws knowledge from all the experts based around Australia that are part of this consortium, and the content in today's slides are also drawn from those experts. So I'll be briefly describing the role of a data specialist in infectious diseases data ecosystem, what the data ecosystem looks like, which is derived from our APPRISE CRE's research structure, what types of data the ecosystem generates and how they inform outbreak investigation and response, barriers and enablers to sharing data and the usage, COVID-19 investigation through open data access and analytics, and I'll leave some time for discussion at the end. So what does a data specialist do in this complex world of infectious diseases data? So a data specialist is a bridge or a central point of information aggregation for clinicians, public health practitioners, virologists, microbiologists, epidemiologists, public health researchers, policymakers, and communities. So a data specialist needs to understand the raw data, understand what context needs to be applied to it to turn it into information, and make it available to experts who add meaning to it and turn it into knowledge. The insights derived from the knowledge turns into wisdom, which is then used by policymakers to make decisions. So it is important for a data specialist to understand the information and knowledge needs across a range of disciplines and also different decision makers in those disciplines. So let's dive into what the infectious diseases data ecosystem looks like. And this is, like I said, entirely derived from APPRISE's structure. So APPRISE, this is the ecosystem that I operate in. So APPRISE has 4 key research areas, and there's a huge range of data being generated in those research areas. Clinical research and infection prevention is generating case report forms, administrative data sets, electronic health records. The laboratory research and diagnostics are generating test data, pathogen information, genomics data. Public health surveillance systems generate immunization data, epidemiological data, public health reporting data. And communities, as an area of research, prioritizes vulnerable populations that experience a higher burden of infectious diseases. We have a strong focus on improving preparedness and response capacity for Aboriginal and Torres Strait Islander people. Hereafter, in this presentation, will be respectfully referred to as First Nations people. And from communities, there are community-controlled data, public health reporting data, administrative data sets that form a part of this ecosystem. Let's take a closer look at the different types of data coming out of the ecosystem and how they inform outbreak investigation and response. Historically, pneumonia has been the predominant indicator of critical illness associated with past influenza pandemics. And patients with life-threatening pneumonia are treated at intensive care units, ICUs, which makes clinical research in ICU settings an important component of both pandemic preparedness as well as response. So an example would be a modular clinical research case report form that collects observational data at different events. So the first event would be hospital admission. So a daily case report form would collect information from first day of hospital admission, second day of hospital admission, ICU admission, day 1 of ICU admission, day 2, and in the event of hospital outcome. Then the modular case report form would have another module, which is the core module that would collect data on demographics, risk factors of people, signs and symptoms during hospital admission, complications, pathogen testing, treatment, medication, and outcomes. And the daily component would also collect data on assessment, what treatments are being given, laboratory results, and results of your chest X-ray. Yeah. So timely and accurate diagnostics are fundamental to understanding, measuring, and mitigating the burden of infectious diseases. So laboratory testing capabilities should be rapid, it should be cost-effective, reliable, sustainable, and available nationally to people. So there's ongoing research happening that evaluates and applies new diagnostics to understand the features of diseases and the pathogens that cause those diseases. So when I say pathogen, it could be bacteria, virus, or other microorganisms that cause diseases. And next generation sequencing data, whole genome sequencing data are extremely important, rapidly emerging techniques for pathogen detection and also understanding transmission. It is the fastest way, I think, to understand genetic features of pathogen and also understand the spread. Public health surveillance systems are essential because they enable the impact assessment, but it can't just be assessed on the basis of this clinical observational studies done in clinical settings. So public health surveillance systems are important to understand the early estimates of transmissibility and severity of a disease. Individuals with mild infections are unlikely to present for treatment and get hospitalized. So it's important to have information collected outside of hospital settings. So those mild infections could be identified through enhanced case finding, through contact tracing of the first few people who present with cases. And community-based public health surveillance are essential to determine the relative number of cases. So there's two kinds of surveillance. There's pathogen-based, which is the bacteria, virus, or other microorganism, so depending on the type of a pathogen, and syndrome-oriented, so set of medical signs and symptoms. And they can be implemented in different settings depending on the group of symptoms or syndromes that people are presenting. So the communities focus on vulnerable population. So the First Nations people in Australia were a significant omission in Australia's pre-2009 pandemic plan. And with pregnant women and First Nations people were more severely affected than other groups during the 2009 pandemic. So there was a critical need to establish ethical engagement and ongoing respectful consultation with First Nations communities. And there is information that needs to be collected, and the data that needs to be collected should be done through respectful engagement as opposed to just focusing on getting the data. And this particular research area should integrate, and it is integrating well into the clinical, laboratory, and public health information systems. So these are the information hubs playing critical role in infectious diseases preparedness and response. And I have been developing case studies and writing up case studies on different types of data that comes out of these systems. So it's not just important to share the data within these information hubs, but across these information hubs as well, because they're all telling us different parts of the story that we're trying to understand. There are barriers and enablers associated with sharing and using data within and across these information hubs. So I'll talk about the barriers based on what happened in the past pandemics and some of the enablers that were put in place as a lesson learned through those past pandemics, and now they're helping improve research in the present day scenario. So in the clinical research and infection setting, there's initially the platforms to collect multi-site data were not very efficient. So if there are different ICU settings in different countries, it was difficult to implement a harmonized way of collecting data across those different sites. And those clinical case report forms were only designed for a particular type of syndromic presentation, and they were not very adaptable. So when we have new emerging infections, people could be presenting with different types of symptoms. There could be different novel types of data that needs to be recorded, which was quite difficult when there's only one kind of data collection tool that's designed for a particular syndromic presentation. It was also difficult to rapidly share and disseminate the findings that come out of those clinical research settings. So now we have harmonized protocols, so case report forms that were developed by global bodies that have harmonized the fields, harmonized the definitions of the data that's being collected through those protocols to make sure that there is consistent information gathering happening across different sites. So when I say sites, it could be different countries, could be different cities within the same country, or different hospitals within the same city. So if there's a harmonized way of collecting information everywhere, it just makes it easy to compare the clinical presentations that people are presenting with, and also understand the severity, clinical characteristics. And multi-site implementation capacity has also improved. Data aggregation has improved collecting and sharing of data from different sites. And there's more information that's being collected when a data collection tool is harmonized and designed to be rapidly adapted to different settings. So I think not just for this setting, I think it applies to data collection in other settings as well, not just clinical, that there is an overarching body that enables the harmonization process that says people need to be collecting these bits of information, and it's important for the information gain. And then those fields and those data definitions are then harmonized and then made available for different sites, so people know what they're collecting, and the information is consistent, and those things can be adapted to different settings. So for laboratory research and diagnostics, if we're just looking at Australia being the example here, it was challenging to share materials, so materials being specimens and data across different jurisdictions. The governance is different. The legal requirements of sharing specimens and data across jurisdictions are quite different. Computational and analytical capacity for genomics was limited. Only few jurisdictions here in Australia could do it. And it would take a bit of time to approve things and send them across, because yeah, that's just how it used to be. I think that's the case. So different countries have different approval processes, which can delay things. So it's not just within the country, but also sharing it internationally. So some of the enablers that were put in place to improve and overcome those barriers were model for cross-jurisdictional information sharings and information gathering as well. So Australia has a multi-jurisdictional outbreak investigation protocol for foodborne outbreaks. I can send more details if anyone's interested. So that's a harmonized way of all the jurisdictions getting together and investigating a foodborne outbreak together and in a harmonized way. And genomics capacity has obviously increased. A lot of jurisdictions here, labs are doing genomics. They're generating their own sequence data. We have a national network of experts, the Public Health Laboratory Network, people who get together and devise strategies for improving diagnostic capacities, and also define case definitions, and come up with guidelines on what the laboratory laboratories across Australia should be doing. And all of these things have obviously improved the research and surveillance capacity today. It's public health surveillance system. So the trigger data for public health response. So the minimum information data set, so MID, some countries call it differently. So the minimum information that's required for public health response, it needs to be defined again in a harmonized way. So everyone should agree that this is the minimum amount of data set that we need. That has been a challenge, but it's not something that it's not people's fault. I think it's difficult to define that. Comparing epidemic data to non-epidemic data, understanding what happens when we're in a peacetime as opposed to when there is an outbreak, and synthesis across health and community settings. And some of the enablers, again, this is an example of influenza in surveillance systems in Australia. So national level information gathering happens every year during the influenza season. There are collaborative working relationships between the public health labs. The data is routinely shared, and these existing systems are currently being leveraged for the COVID-19 pandemic as well. So I think this highlights the importance of building national level partnerships, national level working relationships, and establishing those relationships to leverage those relationships when we have an outbreak. And that is the time to use what we have as opposed to building new things. Communities. So data sovereignty has always been a huge issue. Thinking about community control at every stage of data management. So the data goes through a cycle, collection, then research, and then getting the results out of the data. So the community control, indigenous community control, is lacking in it. I think it's an ongoing process. It's not that we have achieved it, but it's a work in progress. Completeness of data sets, past experiences of First Nations people and mistrust of health services. There are ethical sensitivities. There are many data sets, both administrative and research data sets, that are being orphaned. They're at a risk of being orphaned, and there are initiatives that are supporting the saving of those data sets. And enablers for sharing and using those data. So we've improved research capacity, there's respectful community engagement, and like I said, this is an ongoing process. There are initiatives that are changing the way administrative data sets are collecting data on First Nations people, from First Nations people on identities. These are some of the exemplars of COVID-19 investigation through open data access and analytics. And I'm heavily promoting open data at the moment. So not everything is generated from APPRISE, obviously, but these are the exemplars of what's happening all over the world. And we're keenly watching this and trying to replicate some of these processes locally. So ISRIC, this is an example of clinical research protocols. So International Severe Acute Respiratory and Emerging Infection Consortium. So ISRIC was established as a network of networks to ensure a rapid response to potential pandemics. ISRIC aims to develop standardized research tools, so data collection tools, platforms for data collection and sharing, infrastructure for epidemiological responses, and also enable research in resource-poor settings. So they're facilitating harmonization by developing a case report form, which is endorsed by the World Health Organization for standardized and clinical data collection that will inform local and international public health responses and patient care. They're supporting investigation by developing a clinical characterization protocol that enables clinical data and biological samples to be collected rapidly in a globally harmonized manner. And ISRIC is supporting evaluation by developing clinical trial protocols for the formal evaluation of the efficacy and safety treatments for COVID-19. And what I like about these resources is that they're free to use. Investigators retain full control of all the data and samples. And this is freely available, it's open access, and people who wouldn't have had anticipated these kind of outbreaks and had not developed case report forms can actually use these resources, which also enables harmonization. So the data that will be collected everywhere would be harmonized. This is an exemplar of open genomics data access and analytics. So researchers from universities in Germany, Belgium, excuse me, Australia and the US have used publicly available COVID-19 genome data. So SARS-CoV-2 genome data, the virus that causes COVID-19. So it's a novel coronavirus, and published their analysis using Galaxy, an open source research platform. So all SARS-CoV-2 genomic data available in the public domain were analyzed through Galaxy workflows. This collaborative effort highlights the importance of having access to raw data, and also demonstrates that existing community efforts in curation and deployment of biomedical software can reliably support rapid, reproducible research during a public health emergency. The Global Initiative on Sharing All Influenza Data, GISAID, promotes the international sharing of all influenza virus sequences, related clinical epidemiological data to help researchers understand how the viruses evolve, spread, and potentially become pandemics. So this is another platform which was meant for influenza, but now is being leveraged for COVID-19. So the laboratories all over the world are generating more and more genome sequences of SARS-CoV-2, the virus associated with COVID-19. And they're also generating clinical and epidemiological data associated with the pandemic. All this data are being rapidly made available via GISAID. And NextTrain is a real-time tracking platform of pathogen evolution. So it's an open source platform that harnesses scientific and public health potential of pathogen genome data. So they provide a continually updated view of publicly available data alongside powerful analytical and visualization tools. So the genome sequences of SARS-CoV-2 are crucial to understand the transmission, obviously, and also to design and evaluate diagnostic tests, and to track the ongoing outbreak and identify potential interventions. So this visualization is generated by NextTrain. So it's showing the genetic variation and similarity between different genome sequences sampled from different parts of the world. It's a phylogenetic tree here that is showing how these SARS-CoV-2 viruses from different parts of the world are related by their evolutionary history, and they're color-coded by locations here. I think it's pretty cool. The coronavirus COVID-19 global cases dashboard by the Center for Systems Science and Engineering at Johns Hopkins University. This dashboard has kept me awake for a bit now, and I think has been bookmarked by some of us. It's an extremely good platform, dashboard, visual dashboard that shows total number of cases by countries and also shows cities as well. I think the new feature that was added today, because I'm constantly monitoring it, that in the US we can now zoom in and look at different cities as well. I've not verified that, but I think that'll also be useful. There are other countries that have developed similar platforms. So Singapore, Hong Kong, and Australia has also developed one based on the publicly available information. I think these visual dashboards are quite important to monitor ongoing number of cases. I think one thing I want to highlight is that I know this makes people a bit stressed. I mean, not that we're all very, very stressed, but I think it's also important to look at the total number of recovered people as well and know that there's light at the end of the tunnel. I'm just putting it out there. Right, so key messages. How do we make better decisions for data to improve the data for decisions? So we need to break out of silos. There's immense value in combining information from different systems. We saw today how 3 different information hubs can, along with putting communities at first, can inform preparedness and response. There is a need for standardized and harmonized data fields, formats, and definitions for consistent decision making. We also need to clearly understand the value for synthesizing and aggregating data, and build capacity through infrastructure, skills, people, time, funding, and collaborations during the preparedness stage for better response. So these are my contact details again. Please reach out to me if you have any other questions after the webinar ends today. And these are the details of the groups that I work for. So I'm based at the Peter Doherty Institute and the University of Melbourne. I'd like to acknowledge all these amazing experts, and all the knowledge that I've gained is through APPRISE CRE and working with these people. Professor Jody McLernan, my supervisor, Miranda Smith is our project officer, our prize project officer. Douglas Boyle is a health informatics expert at the University of Melbourne and one of my mentors. Dieter was my master's research supervisor and is a bit of a microbial genomics wizard, and have been a fantastic mentor to me. Ross Andrews, Angus Dawson, Teresa Wozniak, Bart Curry are APPRISE investigators, collaborators, based around different parts of Australia. They're fantastic people, been advising me on laboratory research, ethics. Kylie Cavils is an epidemiologist based at the Doherty Institute. Julian Drews introduced me to the fabulous world of virology and understanding and detection of pathogens. Neil Killeen is my technical advisor. He's been supportive. He's been extremely supportive of explaining the world of data and helping me draw things and helping me transfer the knowledge across different domains. Sheena Sullivan has been extremely important in introducing me to the world of influenza surveillance. It was very interesting understanding how everything works. And Steve Webb has been very supportive of making me understand how clinical research platforms and protocols work. Thank you for listening.
Okay, thank you, Priyanka. So we now have time for questions. Does anyone on the call have questions? Okay, first of all, Priyanka, in your view, is the response to COVID-19 in Australia better than the response we had to influenza in 2009? And if so, how is it better, and to what do you attribute that improvement, if any?
That's a really good question. I will be a little bit defensive and say that I've only been working in infectious diseases for the last 2 years, and I was not even in Australia in 2009 when the pandemic happened. But my understanding is that everything that was implemented back in 2009 and later, which includes clinical research protocols or surveillance systems, are now helping us collect data and at the same time anticipate some of the things that needs to be collected, the information bits that needs to be collected. That would be my understanding. I'm sorry it's limited, but yeah, that would be my understanding. Yeah.
Okay, thank you. And my addition, I guess, would be that it's probably too early to tell. We have a sense of how the influenza pandemic turned out. I think it's still way too early to say how this one's going to go. But I do note that I do see lots of references, as you've done in your slides, to people saying, look, these are the differences between the two pandemics, at least the differences in how the diseases behave. So I think people are certainly looking back for answers. And indeed, I've seen some people looking back to the 1918 so-called Spanish flu epidemic or pandemic as instances of things we can learn. So one of the issues with COVID, Priyanka, that you've identified is the speed with which things are happening. Mm-hmm. So another question was, have you seen any trade-offs between rapidity of getting data and the accuracy of the data that you're able to get?
That I would need to think about where the data is coming from in that context. So if we think about what's the word, repeatedness, or the different, if one type of data is being repeated. So if I look at lab data as an example, if you're getting different genome sequences, but it's from the same virus, that's actually a good thing, because then we can actually cover off and understand what's happening in different parts of the world. But if you're talking about duplication, data duplication, and understanding the accuracy, again, we're in a state of an emergency where we're collecting everything that's possible. So I'd imagine, again, I haven't seen all the data sets that are coming in. I'd imagine there'll be some level of duplication, and accuracy would obviously drop off as it gets more and more intense. The data collection gets more and more intense. I think it's about using that context and knowledge and understanding how to make best use of the data, and also understand that there will be such gaps there.
Okay, so let me try rephrasing that question in a slightly different way, based on thinking about it as you just gave that answer. Would you rather have lots of data where you know some of it's messy and wrong, or a smaller amount of data where you know it's all 100% okay?
I personally like lots of data. I think it's best to have more and then work through the accuracy and understand what's required. I think missing data is more dangerous than lots of data. I would rather have lots of data.
Okay, good, thank you. Any other questions from people in the webinar? There's 70 of you there, and we've had 2 questions so far. Oh, someone's coming back for seconds, but that's okay. Nobody else has put their hand up yet. Were there any new lessons? Have we learned any new lessons from the new outbreak? You talked a little bit about some of the preparedness. Were things, did they look like they were better prepared? Mindful of your comment that you weren't here in 2009. So there's a follow-up part to that, but let's start with the, have we learned anything?
I definitely think that we have. Also, the technologies that we've worked hard, I mean, when I say we, I mean other experts, the technologies that everyone has developed, including genomics and fast, rapid sharing of data, it's all lessons. They're all lessons learned from previous pandemics that we need this. One of the things that it's more of an internal kind of scientific communication that everyone's looking at. So we're looking at the number of tests that are being done as well. And then the number of cases, the positive cases that come out of those tests. I think that's a bit of a positive thing. It's important to see how many tests are being done. I don't have the exact number yet, but Australia has been, I think, one of the best countries that are testing and testing and testing everyone. We've got good capacity here. So that's the denominator data to look at. So that's another thing. I think it's one of those lessons. So it was probably challenging to get that kind of data in the past, but in the past, people have seen how important it is to report that as well, negative tests or as well as positive tests. So I think that's one of the things that I'm seeing as a difference between past pandemic. Again, I was not here, but I've read papers where the importance of test data, denominator data was highlighted. Yeah.
Yeah, and just to follow up on that, does it seem to you, at least in Australia, I'm not going to comment on other countries, as if the government seems to be more prepared to listen to scientists and take scientific advice?
That is a very, very tricky question.
This may be above your pay grade. Feel free to.
It is definitely above my pay grade as well as above my expertise. I don't even have the expertise to translate what the medical advice is being given to. But I strongly feel that medical advice and medical committees in Australia are quite embedded within the government, which is great. I know medical committees and experts who are meeting daily to think about the emerging evidence that's coming out. So when I say it's above my pay grade, I obviously don't have the capacity to or the understanding of how exactly things work, but I definitely know that we're doing really, really well because I know medical experts who can answer this question better, and definitely the government is listening. Yes.
Okay, great. Is it possible for you to go back to the slide with the dendrogram and the map?
Sure.
We've had a request to talk a little bit more about that. That was the question was, please talk a little bit more about it. So I'm not quite sure what the person is looking for specifically there, but maybe if you can just explain that in a little bit more detail. So let's pretend some of the people on the call have never seen a phylogenetic dendrogram before.
Sure. To make it super, super easy, I will use a family tree example. I think that's what may help me understand this when I was learning this. So there's mom and dad sitting here at the root of the tree, and there's kids coming, with the kids being born, and then they make their own families, and then they make their own families. Obviously, in case of this virus, this is not a family, but this is one virus, and the different genetic differences between the different viruses from different countries. So we're looking at that, but this is more of an evolution of that virus. So the root side here, as you can see, the color coded, it's from the root here is from one geographical location here. And as the time progresses, so we're looking at it on a time scale. So from December all the way to March, we can see how the genomic evolution has happened of this virus. and how genetically different it looks. These are very minute differences. So it may look huge from color codes, but they're really, really minute. I think it would be difficult to explain that scale. But we're looking at this, the similarity between those sequences are clustered and clustered within a geographical location, but sometimes they're spread across. So it's really nuanced. There's no specific pattern that we're seeing. Some of the patterns that we can see is obviously there are clusters happening, but as the strains are also traveling across different geographical locations, we can see those differences traveling as well and getting mixed up in the color codes. Not sure if I did a good job explaining that, but
no. So that's helpful. So the follow-up question from that person was, does that help us understand the origin of the virus cases that we're seeing in Australia? Or is that too much of an interpretation to place on the
I think
map?
Yeah, it's because it's across time, right? So we're looking at the time points. So the first genome sequence was isolated, obviously would have one color code because it has one type. And then we're seeing it across multiple days and months, and we're seeing how the virus can look different genetically. Again, these are very minute differences, mind you. So the more data we get, I think the more complex it'll become as the time progresses. But obviously, when you look at the root, the first sequence to understand and plot this phylogenetic tree, it would obviously look quite straightforward here. So I think it would be an oversimplification to say that it's one source. So yeah.
Yeah. So there's a comment from one of the people in the questions who was saying, so it looks like from that a reasonable interpretation is that the cases in the United States look like they are relatively close downstream from sorry, I shouldn't say cases. It looks like the virus variants in the United States look like they're relatively close downstream from the China variants rather than derived from what's happening in Europe, the variations in Europe. Is that a reasonable interpretation?
I think so. Yeah, that's true. Also, I think Europe has been color coded as well. I'm trying to understand that. So although they're geographically quite close, again, I'm also working through this with you. They're quite close to each other. There's different colors assigned to it. I think that gives a little bit of a variation in the colors here. But United States as a huge region has been allocated one color. So that also shows the aggregation to be a bit more dense, I think.
Yeah, okay, that makes sense. Question about, so moving away from the dendrogram, question about what are you working on at APPRISE at the moment in relation to COVID-19? If you could talk a little bit about what you're currently doing at APPRISE.
So currently I'm involved in a project where we're trying to get a research study as a part of public health response up and running. So we've established the research governance and we've established the research questions. It's collecting data and specimens from the first cluster of outbreaks that has happened here. Cluster may be a very technical term, but few outbreaks that have happened here and from few cases of COVID-19, and also gets data and specimens from their household contacts. So it is a project that's been, I think I should have linked that here. We've only just developed the project profile. So if you visit our website, I think we have some things up and running. So this is to understand the transmissibility of COVID-19 within household settings. And that's one project that I've been working on. It has been commissioned by the government here, and we're doing it as a part of public health response, and we've got the jurisdictional participation. So there are states and territories that are participating in the study. It has been a really interesting process getting everything up and running within weeks, when originally such studies would take a year or so to happen. Yeah. So it's been intense. That's one thing. The other thing that I've been approached by a fantastic clinician in ANU is to develop a dashboard. It's an ongoing conversation. I still need to get more people involved in it, but thinking about a dashboard for people working in this space as well as general public and what data visualization would look like for them. So we're thinking on those lines.
Okay, thank you. Question, as it turns out, from two questions that I'll come to one after another from two of my European colleagues, which means they got up at 4 in the morning to listen to this, which is super impressive.
I'm very grateful. Thank you.
Can you comment on the metadata landscape that's enabling the interoperability between countries for this data that's being pulled together?
That is actually a part of the other piece of work that I'm doing for RDA working group that I think it'll go public soon. So metadata, again, the different types of data that I explained, metadata is used differently in the different context. Interoperability, yes, at least for genome sequences, there are different countries participating in the platform and submitting metadata that they have collected to the epi metadata that's added on top of the sequences. So there's a lot of ongoing work in interoperability, and I think there's more awareness now on interoperability as opposed to before. And I think we need people who are not doing public health response right now because they're extremely busy to actually get together and develop some of those guidelines. And I think I'll be quite happy to do that. So yeah.
Okay, thank you.
It's a work in progress.
Yeah. Going back to the testing question, from a data science perspective, perhaps, and I'm interpreting the question a little now, how would you mitigate for inadequate testing capacity? So you've got inadequate testing capacity, as we know, we're not testing everybody, but we're still trying to make good decisions. Can you think of, or can you maybe talk to techniques that might be useful there to make better decisions based on inadequate data?
So inadequate testing or testing data? Sorry, I'm just trying to understand. So if there's inadequate testing, that's obviously a capacity question for individual laboratories.
Let's assume each test that we do is perfect. So no false positives, no false negatives, but we're not testing everybody. We're only testing a sample. So how would you mitigate against that and still try and make good decisions based on the number of tests that we are doing?
Because in this particular context of COVID-19, the evidence has been evolving. So when the testing criteria, it used to be quite narrow because it was seen that only travelers were presenting with symptoms and were testing positive. So as we are seeing more and more evidence come our way, and when I say our, not me, but the actual decision makers, they're actually widening the testing criteria to test more people, which is, again, it's a government, it's a capacity thing. So widening the test criteria is obviously important. Otherwise, because testing asymptomatic people is really, really important, and for that you need to widen the criteria. That's how I would look at it. In terms of information capturing, again, in the individual labs should understand and they should try. I mean, it's a really stressful time for everyone, but everyone's trying their best to make sure that they're capturing enough metadata and information on the tests and whatever they can. I think everyone's doing whatever they can. But the number of tests, again, if we're not looking at the testing criteria, if we're looking at how many tests can one do, that's a capacity question, definitely.
Yep. Okay. We've got 12 minutes before the webinar comes to a close, so I'm now just going to pick some cherries out of the rich banquet in front of me. An infrastructure question. What are the common platforms or methods that you're seeing used to share research data in this space? I guess let's just focus on Australia for now. So in the work that you're doing with, let's say, APPRISE, is this using University of Melbourne infrastructure? Is it using, I don't know, Cloud Store on ARNet? Is it using Galaxy in the cloud? Are there dedicated epidemiology platforms? Maybe if you could just talk a little bit about the technology platforms that's enabling some of the work that you're doing.
Yeah, that's a good question. So until now, before we were in the state of pandemic, there are obviously infrastructure capacities contributed from different universities because this consortium is based across different states and territories here in Australia. So there's a lot of university infrastructure that is being used. A lot of data that comes from administrative and public health side of things. It's obviously the government's infrastructure that is being used. For the research study that we're trying to get up and running, we're trying to establish virtual machines for different jurisdictions around Australia, because obviously they need to connect remotely and access data. So we're using Nectar, and we're using virtual machines that's been allocated through the NCRIS strategy. So that's where we are at. But like I said, I think this is going to grow a lot, and I've got a few conversations coming up for the dashboard thing. I think that's where we'll be leveraging stuff that Australia has in terms of infrastructure.
Okay. And to the best of your knowledge, are people doing work on improving data sharing guidelines? Is this acting as a trigger or a prompt to improve the level of data sharing that we have, or do you not see this as an issue, at least in Australia at the moment?
I think the conversations are moving quite rapidly now. Before this, when I used to talk about data sharing, it was obviously seen as important, but the nitty-gritty and how exactly to do it and how to do it rapidly. Some people try to do it, some people have a need to focus on what they have in hand. But when we are in a situation like this, I think the conversations move faster. I think the positive part is not just the consortium, but our partners and our collaborators in the government. They also see the importance of sharing data rapidly. And everyone's trying to do the best that they can. And we've had a lot of support in this particular scenario when we're trying to get research studies up and running. I think that's what I would say. So from theoretical conversations to moving to actual solutions, that happened during this time. So that actually gives me a lot of hope and makes me happy that things are moving fast.
Okay. And in those fast moving conversations, are people talking about fair guidelines or using some of the fair sharing tools to assess the fairness, FAI fairness of FAIR fairness of the data, or is that not part of the dialogue at the moment?
I think FAIR is still quite new as a concept. I've written about FAIR in some of my internal case studies and documents that I've written up, but it's still a new concept. But I think in the interoperability and findability elements are something that people focus on it anyway. So if I were to talk about a framework of FAIR, they get it because they've always been talking about interoperability and reproducibility and findability anyway. So I think it's there, but it's a framework that people may not be aware of, that there's an actual acronym, there's an actual framework or set of guidelines. That awareness may not be there, but people understand the value.
Okay, so they understand the concepts even though if they don't label it. Yeah. Okay. I'm going to give you a fairy godmother question. If your fairy godmother came to you and said, assume everything is perfectly harmonized and you have access to all of the genomic, public health and clinical data that you want, what other data sets from what other domains would you like to then have as interoperable and available to you for analysis?
That's a very good question.
all of your world is working perfectly. What else would you now like to throw into the mix?
It's not a controversial opinion, but I always think that community participation is really, really important. So consumer participation, community data collected from people, and people who voluntarily participate and then give their data, as opposed to being collected through a body. So I would like that. I would like more people to be involved in the process of, being open with their data. I'm not saying personal identifiable or sensitive information, but just contributing to the world of data. I would really like that.
Okay, so you're not arguing for a Singaporean style, let's track everybody's mobile phone solution.
There has to be a middle ground. There has to be, so that's the fair and that's the middle ground. That's the comfortable part where not everything is open, but what needs to be open should be open.
Yeah, okay. I guess this is also a slightly fairy godmother question. Is there anything at the moment, the processes we follow, the legislation that's in place, the strategies we're taking, that we could improve to deal better either with the current pandemic or for the next pandemic, because there will be a next one? Is there anything that stands out to you as a particular, if you could only solve one thing, what would it be?
Okay, so in just the context of pandemics, I think the merging research and public health is really, really important. I think research should inform public health response, and public health response activities should inform research questions. So if that bridge can be built better, I think we're trying to do that through APPRISE, and I think making that as a systemic change would be great. That always research is considered for public health, and research looks at public health for its questions. I think making that connection stronger, making that bridge stronger would be great. It's happening, but I think I want it to be done better. Does that answer the question, or was that being vague?
So can I just tease that out a little bit? So you're saying that research should look to public health for the public health domain for interesting problems to tackle, or that they should look to the public health domain for rich data sets that they can do things with, or maybe
actually both. I think both.
Okay.
The openness is really, really important. So if a data set is meant for public health response, I think making it shareable and open for research would be great, because researchers can not just look at the questions that they have in hand, but also in the future look back into those data sets and answer some of the questions that might come up. So
okay, so that links nicely to another question, which is possibly going to be the last or the second last one. So in order to make that more possible, this particular questioner says, why can't we have a central database that's minus confidential data, but inclusive of clinical and demographic data that's been matched, to enable us to do this kind of investigation more easily, rather than having to pull together disparate stuff. Let's just dump it all into one big data warehouse in a way that preserves user privacy, but lets us tackle some of these questions.
I agree. On a personal level, I agree. I think not just Australia, but every country. I'm not aware of every country having that kind of aggregated and one point of centralization for information. Some countries may have it or may not. I think we need an international one, and we also need nationalized ones. That will be an ideal world. I think I would love that. But if someone's willing to give me a contract, I'm happy to do it in 2 years' time.
Yeah. Okay. Okay, last question. In your view at the moment, are data licenses a problem? Are they kind of holding back what we're doing? The specific instance that was given in the question was limits for usage of data by GISAID, for instance, but possibly other data licensing issues. Are they something we need to focus on?
I think this is again establishing a balance between openness and public good, and also protecting people's privacy, and using best practices when they're using data. I think de-identified information should have slightly more relaxed license. As of now, we're not facing any problem. Again, I have not explored everything. But it really depends what the purpose is of that data. So if the clear purposes are defined, that the data will be used for these purposes, so then there will be no barrier to make that data available, no licensing issues or other things. I think that's showing clarity why the data will be used, how it will be used, and what kind of results would be generated from that. I think that's important, especially when we're dealing with de-identified data taken from people. With genomics data, it's slightly more easy. So with Nextstrain getting data, I don't see any issue there. I'm not saying it's a simple space, but I think genomics data has far more openness to it, which enables open analytics. People can download things, people can play around with it, which is great. It really depends on the type of data, I think. So right now, because it's a public health, it's a pandemic, it's quite a emergency situation. Everyone's trying their best to do what they can with the data that they have, and also prioritizing the access at the same time, not compromising on privacy and cybersecurity. So that balance, it's as of now, it's happening.
Okay.
It's good.
Yeah, and I think that the point you just made about balance is a really important one. There's a whole series of things that we have to trade off, and there is no one single right answer. There's a series of things that we have to trade off and balance against one another to make the right decision. All right, look, thank you very much for that, Priyanka. Perhaps if you can just flick to your contacts slide so that people can look at that. So in particular, you might want to make a note of Priyanka's email address or her Twitter handle. So thank you very much to Priyanka for doing this. Thank you to all of you for the questions. Stephanie, if you can now go to the closing slide. And the one after. And so this is to remind you that we were hoping to have a physical plenary meeting in Melbourne last week. We didn't, but we've got a virtual plenary meeting. And so if you're interested in any of the topics that we've discussed today and are interested in seeing what the Research Data Alliance is doing in this space, we now have a virtual plenary program. The URL is down the bottom. We would encourage you to come and join some of the virtual sessions that we have underway. Lots of breakout sessions in addition to some of the keynotes like this. So thank you very much to Priyanka for giving this talk and answering your questions. Thank you to all of you for joining us and contributing your questions to the discussion. Please stay safe, practice social distancing, listen to your government's advice, and we'll get through this. Thank you all.
Thank you.